This program is brought to you by Emory University.
Well, good morning, everyone. Thank you for being here as we start another year of our Friday morning Fellows Conference. As you can see this morning, our speaker is Pratik Sandesara. Pratik is a fourth-year fellow. He is in our clinical investigator research track, did his research with Dr. Larry Sperling. He did his undergraduate studies in medical school at University of Missouri, Kansas City, came to Emory for residency where he was an excellent resident, and is going to be an interventional cardiologist starting next year. And as you can see, he's gonna talk about intermittent fasting, and from the looks of him, he's not just talking the talk, but walking the walk as well. So, right. Dr. Sandesara.
All right. Thank you, Dr. Williams. Good morning, everyone. So I'm going to talk about intermittent fasting and dietary patterns for heart health. Is it worth the wait? I'll let you guys decide that at the end of the talk. So the only disclosure I have is I've been practicing intermittent fasting for over a year now, so there may be some biases in there. So I have two objectives for the talk. One is to discuss popular dietary patterns. So these include ketogenic, Mediterranean, and whole food plant-based diets. And then the second objective is to provide an overview of intermittent fasting and its role in cardiovascular health. So as we know, cardiovascular mortality trends in the US were on a decline. And then over the past 5 to 10 years, there's been a plateauing and perhaps even a rise in the cardiovascular mortality. And this has been attributed to a rising epidemic of obesity. So as you can see on the graph here, almost 40% of US adults are obese. And the problem also extends to the youth. About 17% of youth in the US meet criteria for obesity. And along with this, there's an epidemic of diabetes. And as you can see, a steady rise in the incidence of diabetes, approaching almost 25 million adults in the US. And the couple of reasons for this alarming trend, well, one is physical inactivity, and the other is poor nutrition and dietary practices. So this is a graph from the CDC, the one on the right here. As you can see, all the harmful food groups, so added sugar, saturated fats, and sodium, the percent of the U.S. population at or above the limit are, pretty much on the right-hand side of this graph. And then all the healthy dietary patterns, so intake of fruits, vegetables, grains, proteins, were actually below the recommended limit. And together, both of these have contributed to the rising epidemic of obesity and diabetes. And so my first objective, we're going to go over popular dietary patterns. And one caveat is it's virtually impossible to do a nutrition study with 100% control. It's just very hard to get patient compliance unless you imprison people and ensure what their nutritional intake. So many of the studies that we have and a lot of the data are observational that show significant relationships but may not be causal necessarily. And as we know, there are hundreds of diets out there. Some of them are listed on this slide here. And it is estimated that about 40 million adults in the US have tried some form of diet, and about 40% of women and 20% of males are on a form of diet currently. So most of our patients have probably tried some form of diet, whether it's to lose weight or get healthy, whatnot. And one of the popular diets, one of the things that patients have been bringing up is ketogenic diet. And as you can see, there's a lot of media attention, and so for example, this Men's Fitness magazine says, "Cover Star Abs, a gym-free six-pack plan," and then it's talking about is keto diet for you. Women's Health, it's a keto party, healthy, tasty, and fun recipes. And then you have all these books out there talking about, quick keto meals, 30 minutes or less, keto lifestyle for beginners. So a lot of potential misinformation out there for patients. And so what exactly is a keto diet? So the US dietary guidelines recommend our caloric intake come from 3 macronutrients, carbs, fats, and protein. And 45 to 65% of the intake should be from carbohydrates, 20 to 35% from fats, and 10 to 35% from proteins. A keto diet, however, is a very low carb diet, so 5 to 10% of your calories coming from carbohydrates, 70% of the calories are from fats, and 20 to 25 from proteins. And so that amounts to about net carb intake of 20 to 50 grams a day. And this slide here shows the dietary foods that are usually part of a ketogenic diet. So fewer carbs. So here you see natural fats, so butter, olive oil, margarine. Meats are a big part of a keto diet. They're low in carbohydrates, but high in fats and protein. Fish, seafood, eggs, and then all the healthy stuff. So all the vegetables are on the right-hand side where they have more of a higher carbohydrate content, and so they're not as heavy part of a keto diet. And as you can see, you don't see any fruits on here, and that's one of the issues with this diet, as we'll talk about. And so the basic principles of a keto diet is, so you have on this graph on the left, blood insulin level on the y-axis and time on the x-axis. So as you can see, after carbohydrate intake, there's a spike of insulin. After protein, it's a little bit more of a less insulin spike. And then with fats, you barely get any insulin spike. So the principal insulin is a growth hormone. It's basically you store fat with insulin release. And so the principle for the keto diet, you reduce your carbohydrate intake, your insulin levels in the blood go down. So you start burning the stored fat, and your liver breaks them down to ketones, which are then used as a source of fuel for your brain, muscles, and tissues throughout the body. And so in terms of the ketogenesis, in the blood, you can measure this, and the optimal ketone zone, I guess, for a keto diet, it's reported to be 1 to 5 millimolar. And when you get out to 10 plus, that's when you're actually in ketoacidosis, related to diabetes and whatnot. So what are the effects of a keto diet on cardiovascular risk factors? So there's been small studies, and I've aggregated the data here from a lot of these. So you get about an average of 8.6 kilogram weight loss. However, this difference was not evident at 12 months in most of these studies. So short-term weight loss, you get a lower A1C by as much as 2.2%. No difference in blood pressure. You get a lower triglyceride level by average of about 22 milligrams per deciliter. You get an increase in HDL. You also get an increase in LDL by about 6 milligrams per deciliter. And importantly, this diet is very hard to maintain long term, and the attrition rates are around 30%. And so, why? What about mortality or any kind of outcomes data? So we know that a keto diet involves low carbohydrates, and so there's several studies looking at dietary carbohydrates and mortality, and this one from Scott Solomon group at Harvard. So they looked at 15,000 patients from ERIC, which is a 4 community cohort study from the U.S., and then 400,000 patients from the PURE study, which was a international multi-country study where they basically compiled dietary survey data. And so they found a U-shaped association between dietary carbohydrates and mortality. So individuals at the very extremes, so they define it as less than 40 grams or greater than 70 grams of carbohydrates, had a 1.2-fold increase in mortality. And importantly, if you substitute your low carbs with animal proteins or fats, you actually have a 1.18-fold increase in mortality. Whereas if you substituted the low carbohydrates with plant-based proteins or fats, you actually had a lower mortality. And so they found that an optimal carb intake with the lowest mortality was around 50 to 55%. This is consistent with the US dietary guideline recommendations that I mentioned a few slides ago. So another study looked at low carb diets specifically and all-cause mortality. So a systematic review and meta-analysis. So they looked at over 200,000 individuals from 17 different studies and found similar results. So if you look at individuals with a low carbohydrate score, had a 1.3-fold increase in mortality, and similarly, low carbohydrate and high protein score, the protein component coming from animal protein sources, there was a similar 1.3-fold increase in mortality. So what about individuals? So the first two studies were in patients that had no history of cardiovascular disease and no chronic medical problems. So this study by Lee et al. Looked at low carbohydrate diets and mortality amongst individuals that had a prior myocardial infarction. And their cohort was the Nurses' Health Study and the Health Professionals Follow-Up Study. So these two cohorts are longitudinal cohorts, basically health professionals that have survey data, and they follow these individuals for over 20 years. And a lot of the nutritional and dietary studies are coming out of these two cohorts. So here they included about 2,000 women and 1,800 men with a prior history of myocardial infarction. And as you can see, overall, if they took all comers, there was not a significant increase in mortality. However, if you stratified it by plant-based or animal-based low-carb diet, you can see that the animal-based low-carbohydrate diets had a statistically significant increase, 1.28-fold increase in all-cause mortality, as well as a 1.2-fold increase in cardiovascular mortality. Whereas if they substituted the low-carb diet with plant-based proteins and fats, they did not have an increase in mortality. So another study, I think there's a trend here. This one, again, Nurses' Health Study, 86,000 women, and then almost 45,000 men from the Health Professional Study without known cardiovascular disease. And they found 23% increase in mortality with the low carbohydrate diets. So we've established that part of the ketogenic diet involves very low carbohydrate intake, and a lot of these studies show that those are associated with increased mortality. And so what about fats? And as we know, the 70% of the fat intake, in terms of a keto diet, compared to 30 to 35% recommended daily fat intake per the dietary guidelines. So are fats good or bad? And so we have another study here, same cohort, Nurses' Health Study, Health Professional Study, individuals without known cardiovascular disease. So there were over 33,000 events and 3.4 million person years of follow-up. And they basically stratified this by the type of fat intake. So trans fat, which we know is notorious for causing inflammation, atherosclerosis. So this study, they found a 1.13-fold increase in mortality if your fat intake was primarily from trans fat. What about saturated fats? So the daily recommended intake by guidelines is less than 7%. And that's because a diet high in saturated fats is also associated with adverse outcomes. And so in this study, they found a 1.08-fold increase in mortality for individuals that supplemented their diets with that was primarily saturated fats. And so this comes from animal meat products, cheese. On the contrary, monounsaturated and polyunsaturated fats, the ones we get from olive oil, avocados, nuts, these are considered the good or healthy fats. And as you can see, there was a protective effect for individuals that consumed mono or polyunsaturated fats as part of this low carbohydrate diet. And so their conclusion was replacing 5% of energy from saturated fats with equivalent energy from the poly or monounsaturated fatty acids is associated with a 27 and 13% reduction in total mortality, respectively. So in summary, ketogenic diet involves a high-fat, low-carbohydrate intake, macronutrients. So it's 70% fat, and then the carbohydrates, it comes out to less than 50 grams a day. Majority of this high-fat consumption usually comes from animal proteins and from low plant-based proteins. And as we've seen, there's significant weight loss associated with this, improvement in cardiovascular risk factors such as hemoglobin A1C, increased HDL, decreased triglycerides. However, there's also an increase in LDL associated with this. So low-carbohydrate diets, as we've seen, associated with increased mortality. This is primarily due to intake of higher animal proteins, so which are full of saturated fats. And as we know, this is not sustainable for a long term or a long amount of time, and there's high attrition rates in the studies that we looked at. And so I would, because of the ketosis component of this, probably caution should be advised for pregnant women, patients with diabetes on insulin, as well as now with the SGLT2 inhibitors being prescribed more commonly, and the risk of ketoacidosis with that, I think patients should be careful if they're trying to pursue a ketogenic diet. So overall, I think this is a fad diet, and I would probably discourage patients from pursuing this. So we'll move on to the next dietary type, which is a plant-based diet. So this involves everything you see here on the screen. So leafy green vegetables, fruits, sources of basically whole grains, minimal refined sugars, sweets, meat products, mostly in the form of fish. And so it's a quote from Thomas Jefferson, and he recognized the importance of a low-fat, low animal fat diet, back in those days. So I think I'm going to present some data to support some of these claims here. This is a famous Ornish Intervention trial from the 1990s. So this was a small series of 47 patients. They all had plaque visible on angiograms, and they were divided up into two groups. So they were a control and an experimental group. The experimental group underwent a multidisciplinary intervention. So this included a low-fat vegetarian diet, brisk walking, avoidance of tobacco, stress management, and the diets excluded red meat, poultry, fish, basically eliminating any cholesterol and animal fat. And then the patients had a repeat angiogram about a year later, and they found that 100% of the control group had disease progression and symptoms, whereas the experimental group, their anginal symptoms diminished within weeks, and there was actually a regression of plaque on repeat angiograms at 1 year. And so they basically looked at 1 and 5 year mean diameter stenosis here. And the red line is the control. As you can see, there's an increase in stenosis from baseline around 40 to 51.9%. Whereas in the intervention group, there's a regression of stenosis and plaque. Similarly, there's the Esselstyn diet, and showed very similar results. So this was a 3-week intervention of a plant-based nutrition And they looked at myocardial perfusion and what they saw before treatment versus restoration of flow after treatment with this dietary intervention, as well as angiographically, they saw basically they said normal configuration, but you can see kind of a little bit of restoration of flow and plaque regression there. So what about more contemporary data? There's this meta-analysis from 2016 by Song et al. That looked at animal and plant protein intake with all-cause and cause-specific mortality. So here, you see a forest plot here. So this was a study of about over 130,000 patients from the Nurses' Health Study and Health Professionals Follow-Up. Basically, they're looking at whether an intervention substituting animal protein would favor, in terms of mortality, favor a plant protein or alternate source. And as you can see, processed meats, unprocessed red meats are associated with increased mortality and similar to the cardiovascular disease outcomes here. And so their conclusion basically is animal proteins are associated with increased risk of all-cause and cardiovascular deaths. 34% reduction there was a 34% reduction when they substituted 3% of the energy from processed red meats to plant proteins. So another more recent analysis, this is from a cohort in Japan, so about 70,000 patients. This was just published this year. And they looked at a similar, basically did a similar analysis, and we see very similar results where red and processed meats are associated with increased mortality, same for increased cancer, and in particular the red meats for cardiovascular disease. And so similar to the other study, replacement of red meat with plant proteins associated with 34% lower all-cause death and 42% lower cardiovascular deaths. So what about heart failure outcomes? So this was a paper published in JACC recently. They looked at REGARDS, which is a cohort, a US-based cohort where like 20-30% of their patients are in the stroke belt in the South. And they looked at incident heart failure. So these patients had no known history of cardiovascular disease or heart failure. And they grouped them by different diets, by 5 different types. So they looked at plant-based. So the criteria were, cruciferous vegetables, fruits, beans, fish. This typical Southern diet, which is fried foods, organ meats, processed meats, eggs, added fats, and sugar-sweetened beverages. They looked at convenience diet, so pizza, fried potato, Chinese food, looked at sweets and alcohol and salads. I'm not sure where that diet's popular, but so they basically found that the plant-based diet had a 41% lower incidence of heart failure, and the Southern diet had the highest risk of incident heart failure diagnosis on follow-up. And so not trying to convert anyone to being vegan or vegetarian, but to summarize, a lot of these studies basically show that animal-based proteins are likely harmful and increase risk of all-cause and likely cardiovascular mortality. Moving on to Mediterranean diet, something that we probably have the most robust data for. And on this pyramid here, you can see it's basically comprised of whole grains, legumes, nuts, and seeds, fruits, vegetables, olive oil. These are a source of healthy omega-3s, fish, seafood, and very little meats and sweets. And so there's been 2 landmark studies looking at Mediterranean diet. So the first one is Predimed, and there was a little bit of controversy from the original study that was published, I think it was around 2013. This is the most recent publication from 2018. Basically, they realized that when they randomized some of the patients, 2 of the sites did not randomize patients appropriately, and there were some enrollment of family members of some of the patients that were randomized. And so they went back and redid the analysis here, and it retracted the original paper and published this second paper. And essentially, the results are very similar. They excluded patients that were not randomized appropriately first and got similar results. And so on the left here, you can see the Kaplan-Meier curves here for the primary endpoint of acute myocardial infarction, stroke, or death from cardiovascular causes. And there was about a 30% reduction in these outcomes compared to the control. So they had 3 groups in this study. So there's a control diet that just received counseling. There's a Mediterranean diet supplemented with nuts, and a Mediterranean diet supplemented with extra virgin olive oil. Both of these had similar reduction in outcomes. Interestingly, there was no difference in total mortality amongst the 3 groups. And so the other study, landmark study, was the Lion Diet Heart Study. This was done here in the US, and this was done in patients that had a prior myocardial infarction, so a secondary prevention population, higher risk. And they found a 47% reduction in recurrent MACE. The results were so positive that they actually ended the study early. And they, as part of the study, they looked at traditional risk factors. So there was an improvement in weight, blood pressure, blood cholesterol. So although we've talked about plant-based diets being healthy, is there such a thing as an unhealthy plant-based diet? So this study looked at healthful and unhealthful plant-based diets at risk of coronary heart disease. So they created a score where they looked at consumption of meats, fish, as well as sugar-sweetened beverages and grains, and stratified them into 3 different groups. So there was a unhealthy plant-based diet, there was a plant-based diet index that was everyone, and there was a healthy plant-based diet. And as you can see, individuals in the unhealthy plant-based diet had a higher risk of coronary heart disease, and so these included patients that were supplementing their diets with animal proteins, with refined sugars, sugar-sweetened beverages, et cetera. Not all vegetarian diets are healthy, as we know, and this study essentially just proves that. And if you look at the sources of food consumed per day, increased animal foods and less healthy plant foods are associated with higher mortality. And so higher intake of plant-based diet index rich in healthier foods was associated with a 25% lower risk of coronary heart disease, and a plant-based diet that emphasized less healthy foods associated with a 32% higher risk of coronary heart disease. And so this was shown in a sub-study of the Epidemic trial. So basically they looked at pro-vegetarian food pattern and mortality. So they did a post-hoc analysis of the original trial. And individuals in the very low pro-vegetarian food pattern had basically a higher mortality compared to those in the highest pro-vegetarian diet food pattern. And so their conclusion was there's a 41% lower mortality in the higher pro-vegetarian pattern. So again, proves the point, not all vegetarian diets are healthy. And so the question is, why is animal protein harmful? And one of the hypotheses is trimethylamine N-oxide, or TMAO. And basically, the thought is that foods such as eggs and meats are rich in phosphatidylcholine, choline, and carnitine, which are all processed by the gut microbiota to TMA, or trimethylamine, which is then absorbed and converted by the liver into TMAO. TMAO is linked to increased platelet hyperreactivity, thrombosis, inflammation, and essentially increased adverse cardiovascular outcomes, myocardial infarction, stroke, and heart failure. And overall, their conclusion was that vegans and vegetarians have a lower circulating TMAO level, and fecal TMAO generation capacities are lower than their omnivore counterparts. And specifically, diets rich in red meats are associated with higher circulating TMAO levels. And this may explain the increased mortality associated with animal-based proteins. And so this was a study done by Stanley Hazen's group at Cleveland Clinic. They looked at basically looked at cardiovascular outcomes based on TMAO levels in the blood, and individuals in the highest quartiles TMAO detected in the blood had a 20% increase in myocardial infarction, stroke, or death. And so, in summary, plant-based diets emphasizing vegetables, fruits, whole grains, legumes are associated with a lower mortality, especially a Mediterranean-type diet, which has the most robust data. Unhealthy plant-based diets that emphasize processed foods, sweets, refined grains, and animal proteins is associated with increased mortality. One of the pathophysiologic mechanisms for this may be generation of this TMAO due to gut microbiome alteration, and therefore consumption of animal proteins, particularly red meats, may be associated with higher TMAO levels, adverse outcomes. And after all of that, even our president is going vegan, it seems like. So moving on to my next objective, and probably a more interesting part of the talk from a personal experience standpoint, we're going to talk about intermittent fasting and its role in cardiovascular health. So the principles of caloric restriction, and Benjamin Franklin recognized this, that in general, mankind, since the improvement of cookery, eats about twice as much as nature requires. And that's certainly true for the American population. So over half the US population exceeds the total caloric intake recommendations, including sugar, saturated fats, and sodium. The eating patterns have changed. So Americans are eating less. They're eating three regular meals less, and are snacking more frequently. There's only a 5-hour time period when there's no consumption of food between 1 and 6 a.m. And late night eating in particular is associated with greater risk of poor cardiometabolic health, 1.62-fold increase in risk of obesity. And these irregular feeding patterns kind of entrain the clock genes that regulate metabolism, and it's thought to be one of the mechanisms for obesity and diabetes and cardiometabolic diseases. And so there's been studies of caloric restriction, initially looking at longevity and aging. First, they looked at mice back in the 1930s. They were either on an ad libitum diet or a calorie-restricted diet. And the rats that were on a calorie-restricted diet lived longer. So next, we looked at our closest relative, the rhesus monkeys. So there were two studies, the NIA and the National Institute of Aging and the University of Wisconsin-Madison rhesus monkey studies. And although there were differences in the two study characteristics and the diets that the monkeys were placed on, overall there was an improvement in survival, maintenance of weight on a calorie-restricted diet. And so what about data in humans? So the CALERIE trial is the only randomized controlled trial that I'm aware of that looked at the effects of caloric restriction. And basically, they had about 200 subjects. Most of them had a BMI around 25, and they randomized them 2-to-1 to a 25% calorie intake restriction versus just normal food intake. And individuals in the calorie-restricted diet had improvement in pretty much almost every cardiovascular risk factor outcome. So 12% reduction overall. So initially they were achieving, or their goal was to get a 25% reduction in caloric intake, but as with all human dietary trials, it's very hard to be compliant. So overall, they were only able to achieve a 12% reduction in caloric intake in the intervention group. So, but they saw an 8.4 kilogram weight loss at 1 year and a 7.5 kg at 2 years. So, you know, fairly stable. A 10 milligram per deciliter reduction in triglycerides, There's a reduction in LDL, increase in HDL. There is a reduction in triglycerides, and as well as a reduction in blood pressure. All of these were statistically significant compared to the group that did not get any caloric restriction. And so that leads me to intermittent fasting. And what is intermittent fasting? So it's basically, I think, a form of caloric restriction, essentially. But you're essentially, there's two forms. You can do a time-restricted fasting, where you fast for 16 to 20 hours. And in those 16 to 20 hours, you only consume zero-calorie beverages, so water, coffees, and teas. Or you do what's called an alternate day fast, where it's like called a 5-to-2 strategy, where 2 days a week you consume only 500 calories, or 25% of the daily caloric needs, and then the rest of the 5 days it's ad libitum eating. So what are the reported pathophysiologic mechanisms for possible benefits? So similar to a keto diet, essentially, when you're in that fasting period, you are reducing your insulin release. So there's ketone body production, and there's breakdown of fats. So that's one of the reported mechanisms. There's a reduction in oxidative stress, inflammation, and increased lipolysis. All of these lead to weight loss and then associated benefits in cardiovascular risk factors. So there was a HA scientific statement a couple of years ago on mealtime frequency and implications for cardiovascular disease. And they basically summarize, there's a summary of all the trials looking at intermittent fasting. And I've summarized them all later, but I want to point out the duration of the trials are very small, and the number of subjects anywhere from like 10 to 40. So these are fairly small trials, and so just kind of exploratory data. Again, same thing. This is the alternate day fasting regimen, and just very short duration, 8 to 12 week trials. And these are the reported benefits basically summarized from these studies. So body weight decreased by 3 to 8%. There's a reduction in total cholesterol, 6 to 21%, and LDL reduction from anywhere from 7 to 32%. The HDL remained unchanged, interestingly, in most of the studies. The triglycerides decreased 16 to 42%. There's a drop in systolic and diastolic blood pressures. There's a drop in fasting glucose, mostly in individuals with prediabetes. Individuals that were healthy and didn't have impaired fasting glucose, they didn't have a big change in their glucose levels. And the fasting insulin levels decreased, and then there was a reduction in insulin resistance. So all of these benefits from one of these two fasting modalities or methods. And so their conclusion, or one of their statements, is intermittent fasting approaches appear to be feasible to help patients lower caloric intake consistently. In the long run, approaches such as intermittent fasting may simply provide another way to help patients be more intentional about consuming energy within a given time period. And so, as we know, very hard to adhere to a caloric restriction, as we saw in the CALERIE study, and a lot of these studies, keto diet, very hard to follow a strictly outlined regimented diet plan. So this is one way to reduce their caloric intake in a way that may be more sustainable. And so there's a N of 3 study that I'd like to talk about. This is one of my friends who is an internal medicine resident, myself, and a dermatology resident. All are South Asian males, blessed with the South Asian genes. And so you can see the starting weights here, 165 to 210, the duration of intermittent fasting. So for me, it's been over a year now. And then all of them basically essentially followed some form of time-restricted feeding. So the 16 hours of fast and 8 hours of feeding. If you can do a very stringent 20-hour fast and 4 hours of feeding if you're looking for a more quicker weight loss. Importantly, it's not just about one component. I think all of us recognize the importance of physical activity. And so, we all exercised 5 days a week. Reason for fast was weight loss. And So moving on to the results. As you can see, there's a 15 to 35 pound weight loss, and these basically have been sustained over, almost 1.5 years out now for the longest person. And, we're all continuing to be physically active. So essentially, this is a way to reduce your caloric intake in a way that's more sustainable, but also recognizing that it's more than just diet. It involves a comprehensive plan, including exercise. And so, in summary, intermittent fasting, it's more of an eating pattern rather than a diet, I think. And the two options, time-restricted feeding or alternate day fasting, are, two ways to potentially attempt intermittent fasting. And as I've shown, there's improvement in several cardiovascular risk factors. And it's really feasible without any significant downsides. And with the only caveat, same thing as keto diets, individuals that are poorly controlled diabetics or on insulin or on SGLT2 inhibitors, they could be at risk for ketoacidosis with the period of ketosis that happens with the fasting. However, we do need long-term outcome studies and more long-term studies to kind of help establish this as a routine part of our practice, I guess. And so I'll end with one last quote from Benjamin Franklin. It says, "One should eat to live, not live to eat." All right. And I want to thank the three residents. And
first of all, what a fantastic summary. You put a tremendous amount of work into this presentation, but excellent job. And so you point out well, and you've probably heard me say the Latin derivation for diet is dieta, and so that's a way of life. It's not I'm on a diet this month, I have to eat this or I can't eat that. And it's more dietary patterns or life patterns that we really want to focus on for ourselves and our patients and our families and our friends, etc. But
yeah.
I'm sure when you start getting asked questions about ketogenic diet, and so let's just say you get asked about a ketogenic diet, how do you respond to somebody and try to reshape that in terms of a healthy dietary approach?
So, with the ketogenic, you can make it healthy, but it requires a lot of work. So you have to work very closely with nutritionists. And so, first thing I would ask them is what's their goal? If their goal is just, I want to lose 10 pounds, for my wedding's coming up, then yeah, maybe they can try it for a short period of time. But I would really talk to them about the fact that it's really not sustainable for a long term. And in terms of a lifestyle change, I would do a modified keto. So I would probably incorporate a little bit of intermittent fasting, probably which induces that ketosis. But then at the same time, tell them for their dietary patterns, minimize the foods that I talked about, get their protein from plant sources, and the fats, minimize the fats, saturated fats, and substitute them with like olive oil or nuts, which are healthier. So I think there's a way to make it more healthy and more comprehensive, where there's not components that over a long run will do more harm than good. So.
Probably more of a comment than a question, but one of the limitations with the Mediterranean diet for a lot of our patients is access to those not inexpensive ingredients, that sort of thing. Sort of the food desert or semi-food desert concept. So I think The intermittent fasting might be a viable alternative for some of our, patients, or like you said, sort of a modified approach and incorporates some aspects of both, for a patient that does live in an area where they may not have the same degree of access to, fresh salmon and that sort of thing, or have the means to, eat that diet on a regular basis.
Yeah.
Just any thoughts on that?
So I mean, with the intermittent fasting, I mean, you do restrict the amount of calories you take in, with the time restriction. So you can only eat so much in a 4-hour, 6-hour window. And so I think overall, the amount of unhealthy foods you eat probably would go down. I think there's really hardly any downsides to intermittent fasting. So, and then you kind of tell them to incorporate as much.
Increase syncope, maybe?
I mean, I haven't experienced that in none of the, maybe. I think you just try to incorporate as much of the healthy foods as you can, but overall, their intake of unhealthy foods would decrease. So I think that would be a benefit. Yeah.
What's your opinion on the alternatives to meat, like Beyond Meat and Intermediate and this kind of stuff? Because in many patients, we know that red meat is not good, but so many patients are already, 50, 60, 70 years of age, and it's very difficult to expect that they will profoundly change their dietary patterns. So what are these alternatives?
So that's a great point. A lot of these diets were actually, the cohorts were like mean age was around like 40. And so they've already made it to 60, 70. I mean, I think moderation may be key at that point. And so, you just try to get them, maybe substitute, the red meats for fish if they really need to have a source of meat, to more healthier options. But I think moderation would probably, we'd start with that. Yeah.
The preceding program is copyrighted by Emory University.